Welcome to the Healthcare Compliance Pros July 2017 webinar about key updates proposed for MIPS in 2018. This presentation is being recorded. The recording will be published in our Insider newsletter next week, and we will also be available on your compliance website landing page under News and Events. At this time, I'd like to introduce the presenters for today's webinar, Eric Christensen, our Director of Client Services, and Chad Schiffman, our Director of Compliance. If you have any questions during the webinar, please post them using the GoToWebinar dashboard so we can address them during the presentation. Any questions that we are not able to address during the webinar will be followed up via email. Now, I'll turn the webinar over to Chad and Eric for today's presentation. Eric.
Hey, thanks, Nicole. So, just some background before we get started. First of all, please type in questions. We'd like to answer questions during the presentation as they're presented in context. That will help us, but if we don't get to them, know that we will answer the questions at the end, or we will answer them possibly as part of the Compliance Insider, or you can always submit your questions to support@hcp.md. And we will follow up with those and get those answered for you as well, okay? So obviously here we are, we're in MIPS. MIPS, we're in Pick Your Pace, year of 2017. This was actually adopted, obviously, 2016. We had a proposed rule, if you remember, back in May of 2016. That proposed rule was heavily modified for the final rule that was adopted in October 2016. So we want to understand what we're doing with this proposed rule as we move forward. So we're in the proposal, and there are some key timeframes with regards to that proposal. Okay? So first, we have this concept of the proposed rule came out. Can you change the slide, Nicole? We have the quality payment program, the proposed rule with MIPS, and the alternative payment models. If you're participating in APMs, you know it, okay? If you're not participating in APMs, and more than 58% of clinicians are not able to participate in APMs, you're participating in MIPS. And that's the way that you're participating in MIPS moving forward. But there are key changes to how MIPS is going to be introduced or populated or configured for 2018, second year, okay? So as we move into, MIPS was, obviously the PQRS system and the value modifier, and the meaningful use has turned into advancing care information. Next slide, Nicole. Okay, so we've got, now I'm not going to go into all of what MIPS is and how MIPS was rolled out. You can get onto our website. We did do a webinar back in November of 2017 that was the final rule and talked about scoring and talked about different quality models, talked about the clinical practice improvement activities. All of that can be found either on that webinar or refer to MIPS, type MIPS into the search bar in our Compliance Insider, and it'll pull up all of the articles regarding MIPS for the first year for Pick Your Own Pace. Okay, so the primary focus, PQRS, VM, EHR, electronic health records, all turned into quality. We turned into cost, which is not going to be affected in 2017, and we turned into advancing care information. So now, Chad, you've been participating in the MIPS CMS portal and all of the discussions on that. How is MIPS changing for 2018? What are we having for year two of the merit-based program, Chad?
Well, some of the changes that we're going to be seeing, I believe we'll cover here in just a few minutes, but some of the big changes that we're talking about is they're really looking to make it less burdensome for clinicians. And as we'll see later on future slides, one of the ways they're going to do that is increasing that low volume threshold. They're going to offer some different feedback mechanisms, and I'm hoping that we'll be able to cover that as we move on through this webinar.
Yeah. So one of the things we can do is make sure that you're checking your eligibility. They've changed the eligibility checking to the front page of the quality payment website. So qpp.cms.gov, you can check eligibility by NPI there. That's been especially important to some of the groups that we've been helping here at Healthcare Compliance Pros, is making sure that you're eligible, and that groups within or individuals within your group are eligible, because again, its eligibility is determined by NPI. Even though you may be reporting as a group, we want to check your eligibility based on your NPI, okay? The proposed rule obviously came out in June of 2017, and as I mentioned, the proposed rule can vary greatly from the final rule. So we want to make sure that if you want to post comments, if you want to read through or understand after the end of this webinar how those proposed changes affect MIPS, make sure that you're posting your comments by August 21st of 2017, okay? And again, you can go to the QPP website, qpp.cms.gov, and you can post comments, okay? But the key impact of year 2 was to make it less burdensome for clinicians. Now, you know, we've had a administrative change, we have a new CMS director, we have a new HHS secretary who is actually a former private practice orthopedic surgeon. So that process now is going to become less burdensome. We're seeing that oversight possibly being lessened. A new CMS director could take a whole new slant on MIPS. And we're going to be going over what those changes are as we move forward in this presentation. So again, Chad, you've been on this. Other than the less burdensome, any other key oversight issues with what we've been seeing for the proposal for year 2?
Well, and I think, you know, as we start with, let's just go ahead and start with Seema Verma and what she said, you know, where she said, by proposing the proposed rule, their aim is to improve Medicare by helping doctors and clinicians concentrate on caring for the patient rather than filling out paperwork. So that's one of the main things we're seeing, is they are really looking at 2018 as yet again another transitional year, keeping with their theme and really focused on making it less burdensome. So as we move forward, I think we'll talk about some of the virtual groups and things like that that we'll be presenting in this webinar as well, which are all part of what they've released with their proposed changes for 2018.
Well, as a private practice doctor coming in as an HHS secretary, I'm sure that part of his, you know, oversight is how does the doctor-patient relationship evolve? I've been in EMR and practice management, you know, for more than 20 years. The implementation of EMR really, you know, disconnected the physician from his patient. You know, I heard all of the, you know, and I'm preaching to the choir, and anybody on this conference or this webinar, you know, the doctor didn't even look at me. The doctor didn't touch me. He didn't spend time with me. You know, it produced a barrier. So making it less burdensome for not just for clinicians, but for the staff. You know, how did this impact not just the physicians, but the staff as well? So one of the ways that we'll be doing that on the next slide is this concept of low volume threshold, okay? So we're going to be moving the threshold for 2017 was 30,000 in Medicare Part B and 100 or more Part B beneficiaries in 2017. The proposed rule for 2018 would be greater than 90,000 in Part B charges, or. So it was an and before in 2017, now it's an or, but they've raised the thresholds. 90,000 or greater than 200 beneficiaries or patients seen within that same year as well. Now, we've worked with some clients here at Healthcare Compliance Pros that did not qualify and that were looking at voluntary participation. And there were some barriers to that as well. Now, I don't know about voluntary participation, why they wanted to get into that, other than maybe they felt like they were going to be forced to in 2018. Now, we're seeing that the thresholds are moving up. What's been your experience, Chad, with these low threshold providers?
Well, I mean, it's been a lot of their habits, and you know, were already in place with what they were doing with meaningful use, with PQRS and those types of things. So just innately, they were still continuing their efforts and may not have even realized what they were doing. So once they found out through whether they received their letter from CMS stating that they are not an eligible clinician based on the low volume threshold, or they checked that portal and determined that, the thought process was, well, let's go ahead and make sure that you're prepared for 2018, because we actually expected that the low volume threshold would actually decrease and increase, you know, the amount of providers that were being required to participate in MIPS. So now we're thinking, continue these efforts, but also let's focus on 2019, because we'll see, you know, how it transitions, and who knows what comes about with the final rule, but might as well still remain prepared, but also, as CMS's guidance is suggesting, make sure that you're also focusing on your patients at this point. So it's a good opportunity to really, you know, make some of those other areas in your practice solidified if you're considered a low volume threshold.
Now remember, low volume threshold is based on NPI, not by group. We'll get into virtual groups here in just a moment, but within your group, you may have some who are still participating, you're still working workflows in your EMR and your data collection process, but they could be part, not necessarily part of your group's reporting as far as metrics that they're reporting on. Now, based on this change and the exclusions in this change, CMS estimates that 36% of clinicians will be eligible to participate. Now, that's a low number. That's less than 50%. But those 36% of physicians or eligible providers that are available that can participate represent 58% of eligible charges. So although the number's low, 36% will participate or be allowed to participate based on this low volume threshold, it does represent the majority of Medicare Part B charges. So they're still going to be picking up the majority that way as well. So now we have this low volume threshold, we have them reporting as a group, but how do we get some of these other groups together? Well, CMS in 2018, well, in the proposed rule, in the promises or all the literature or all of the press releases and all of the talking points from CMS has talked about this concept of virtual groups. You've got solo providers, you've got some of these rural networks where they don't have the ability to come together as a group. Well, that's the virtual group proposal for 2018. Now, virtual groups can be a combination of solo providers or groups with 10 or fewer eligible clinicians can come together to do reporting on the MIPS standards. Quality, accounting for care information, clinical practice improvement activities can form these virtual groups. And remember, under clinical practice improvement activities, one provider in a group can make the entire group eligible for that improvement activity. So virtual groups will be able to pull together multiple improvement activities across diverse geographics or diverse practice size or practice types to participate in some of those improvement activities. Okay? Now, regardless of location, regardless of specialty, they can come together and form these groups. Chad, what's been the read from CMS on virtual groups? I mean, this was promised. This was the kind of a carrot for these smaller providers back when they first originally announced MACRA and the MIPS implementation.
Well, I think they're expecting that this is going to help a lot of these smaller providers who were unsure about which measures to report on do so more effectively, to make sure that they're eligible for those performance bonuses and positive adjustments. So that's what the read's been basically on that, you know, by encouraging whether it's a solo group with a group of 10 or fewer, whether it's an orthopedic surgeon in Texas or an allergist in Arizona that want to come together and join with maybe even 9 dermatologists. The thought is that it would be less burdensome on them to be in a virtual group and be able to participate in MIPS that way.
Now, HCP has seen this with our own providers in MIPS participation and MIPS preparation that we've done. We've had some solo or small practices that have been struggling to meet some of these standards and to understand the direction that they should be going. These virtual groups and the combination of these virtual groups could be very helpful to them for MIPS reporting moving forward into 2018. Now, another point that we'll bring up later on an additional slide is now they've enhanced the ability to use multiple reporting methods. Now that's going to be especially important when we talk about virtual groups, because you may have one group that's going to be using a web interface, you may have EMR, you may have clinical data registries, those different reporting mechanisms, even down to attestation. Some of the measures are still attestation-based, are still going to be able to be reported across this virtual group through different portals, depending on their specialty, depending on how their EMR is configured. We'll have different standards for that. We'll talk about that here in just a moment. You know, one of the biggest scary points, or one of the biggest talking points, in fact, when I was Bob Tennant at the MGMA conference last year, talked about this concept of certified electronic health record technology. He brought up the fact that, you know, as of that time, November 2017, there was only one major manufacturer, Epic, who had any EMR that met the 2015 Certified Electronic Health Record Technology standard. And it was a big scare of, is your EMR going to meet that standard? And the problem with it is that clinicians really didn't have any ability to affect this. Their EMR vendor was either going to meet the standard or they weren't going to meet it based on the timeline. So CMS looked at this, they pushed back on it. They're going to encourage use of 2015 standards in 2018, but the EMR vendor is really in control. And even if they're not in control, or they do produce a product that meets the 2015 standard, what's going to happen to you as a provider or as a clinical group on getting hardware installed, getting patching, and getting upgrades done to meet that standard? So we're pushing back on the 2015. Now, 2014 health record technology was a requirement for 2017 in the transition year. It will still be able to be part of your process for 2018, okay? So, again, clinicians didn't have control over this. CMS understood that the EMR vendors were not going to meet this standard, and that clinicians didn't have control of what their EMR vendors did, so they pushed back on that. Is that the read that we got from CMS as well, Chad?
Yeah, it is the read that we got. And then I think that's why they're just really focusing on encouraging for 2015. They'd like to see everybody get current and using current technology. So, you know, for those that do so, there is some talk that they are going to offer some bonus money that will be available for encouraging the use of 2015 CEHRT. So, you know, but if you can only participate by virtue of using 2014, you won't be penalized in any way during 2018.
Well, even in 2017 with Pick Your Own Pace, we had some groups that had very little EMR adoption that still managed to avoid the negative payment adjustment for the 2019 year, because we just had to get that one reportable metric. And we did that for some groups that had very low, I would say very minimal EMR implementation for 2017 on the Pick Your Own Pace. That will not be a standard that can be adopted for 2018. You will not be able to meet a minimum standard just to avoid that negative payment adjustment. So we will need to make sure that you have health record technology in place and that you've completed all of the ACI, or the Advancing Care Information standards. That's the security side, that's the patient portal, the e-prescribing. All of those standards have to be met. The coordination of care through acceptance, you know, of a care plan. All of those will have to be met, and your record technology must meet those standards, but they don't have to necessarily meet the 2015 requirement. Now, another thing that we're seeing on pushback from CMS is this idea of complex patients. Okay, so CMS is proposing a one-time consideration for complex patients in 2018 for up to a 3% bonus. And this is bonus points for complex patients. Now, how does this impact? It's not a 3% bonus on your billing. It's just 3% bonus on the points for your care, your quality measures. Is that correct, Chad?
Yeah. So, you know, their goal with that bonus was to, for complex patients, is the hopes that providers would continue to provide care for those complex patients, providing them that excellent care, and, you know, avoiding the MIPS eligible clinicians who care for complex patients, trying to help them not be at a disadvantage so that they are still encouraged to participate in MIPS. That's really their goal with it. And you know, patient complexity takes into consideration a multitude of factors, such as whether it's, you know, factors such as health status, medical conditions of patients, as well as social status as well. So those are some factors to consider when determining if you're working with complex patients.
You know, when I'm talking with my clients with MIPS and participation in MIPS, we looked at, you know, are you reporting on measures that are just easy to record, or measures that actually impact your practice and impact your patient care? Complex patients and the recording of some of those metrics to meet those standards really are where the traction is going to be with you and your patients in the type of care that you're delivering. So, for example, if you're doing, you know, smoking cessation or BMI calculations as part of your practice, but it really doesn't impact you. You know, you're a dermatology practice, what does BMI have anything to do? It's just an easy metric for me to report. So now complex patients and doing the care coordination of that is going to give you a bonus and really should be give you some traction on patient care that's specific to the care that you're delivering to that patient in your specialty. So with that in mind, with complex patients, now we're changing how we're weighting. In the weighting of categories. You can see in 2018 they pushed cost back again. It was supposed to be 20% in 2018. Cost factor was reported based on your claims submissions. You didn't necessarily have any control over the cost factor, although CMS was giving you reports on how your cost measures could affect your reporting. But CMS isn't going to be taking those into account in 2018. Quality will still be at 60%, advancing care information 25%, improvement activities 15%. Now remember, ACI is an all or nothing. You must pass all of the ACI, or advancing care information legs, there's 4 of them, to be eligible in any way for quality measures. Okay, and if you have questions on that, you can go back to the webinars or other white papers or articles that we produced on MIPS. But quality and the standards will be the same, or at least are proposed to be the same, for 2017 and 2018. But cost ramps up dramatically in 2019. So you're going to be wanting to look at your reporting from CMS that you're getting on where your cost numbers are across your specialty and across your billing codes. Right, Chad?
Yeah, absolutely. I mean, that's just staying consistent with our gradual ramp up. We kind of thought they would do that in 2018, so I think it should be welcomed by most providers to see that happening in 2019 at this point. So.
Okay. So, you know, cost just ramps up considerably. Nothing else moves. So advancing care information, improvement activities, just quality gets cut in half, bringing into that cost matrix in 2019. Okay. Now, we talked earlier with this virtual group concept about flexibility in submissions. And that's going to be key, not just for virtual groups, but it could be key for how you're doing data collection or what mechanisms you're reporting out of. If you're using a data aggregator, if you're using a clinical data registry, or you're using your EMR that has practice management in it, and they're aggregating your data for submission, you have a little bit, it's more streamlined the process for you, okay? Now, some of those are still requiring attestation of a number not 0, so you've got to report at least a 1. Say on an e-prescription, you have to report that you've at least done 1 e-prescription, but again, you have that ability. So virtual groups, especially in this flexibility, are going to be very important that you have different mechanisms for reporting measures across these groups and across specialties in multi-specialty groups. So that could equally be important. What's your read from CMS and what you've attended, Chad, on this flexibility concept? Has that been a pushback from the providers?
Well, yeah, so pretty much in 2017, what CMS was stating is that they are going to provide feedback on 1 submission method for 1 category. So in other words, if providers submit quality measures, say, by claims, they would get feedback on that. But if they're also using other mechanisms to submit, or for quality measures, whether it's registry or EMR, they're going to take the highest percentage and give you feedback on that. So with this, now they'll take into account all those measures that you submit in multiple ways in 2018, so that you can get credit for those and feedback on those measures, whether it was submitted from your EMR, whether it was credited for a claims or your registry, or even attestation. That way you'll get better feedback on how you're actually performing for MIPS. So I think that should be pretty excited about this. Actually, it should help providers a great deal.
Okay, great. Thanks, guys. We do have a couple questions here that came in I wanted to bring up. We wanted to find out here from Jenny. She wants to understand why CMS said providers should choose one submission mechanism per performance category.
Okay, so that was previously that was during the transition year that they said they should choose that because that's how they were going to actually provide feedback. Now they're going to change that in 2018 to where you can use multiple submission methods to get credit for that measure.
Perfect. Okay, and then I've got another one here from John. He wants to know, what does CMS mean when it's about caring for complex patients, and how does that impact MIPS eligible clinicians?
So our read on that is that complexity is going to take into those multitude of factors like we talked about earlier. It's the patient health outcomes, how those are impacted, whether it's through health status, medical conditions of patients, and social risk factors. We could dive into it a little bit deeper and find out exactly what makes up a complex patient, if there's actual codes that are associated with that, for example. But we could certainly dive into that a little bit further and get them a more formal answer. I'd be happy to do that.
That's part of what we're doing under our MIPS program with our clients, is helping them determine those code sets that would determine complexity. Okay.
Perfect. That's the others. Anyone else have any other questions they'd like to address here? Don't see any
Two
more
questions. Two
Yeah.
questions. So Chad and I must have knocked it out of the park here for
I hope so.
for all of 100 attendees. So again, these are proposed rules. I think you need to be looking at, if you have some issues with the proposals and the changes. I generally don't see any significant changes where it's not positively impacting the practice. So, for example, you've got the complexity issue, you've got the different submission mechanisms, you've got the virtual groups, the move back, the pushback on the EMR version. All of these are positive impacts, lessening burden for 2018. So no negative impacts that I can see. Okay.
We actually just had a few more come in.
Yeah, I see that.
Here's one for you. Okay. If a provider belongs to a group personally and it does not qualify as an EP, would the group's reporting affect him?
Okay, so our understanding on that is that their group reporting would affect him to a certain extent, but he wouldn't be eligible for any performance anyway. So really, it's more like the EP, by not participating or not having measures that qualify, would change the percentage overall. But really, you're only going to get feedback on those who actually are eligible by virtue of their MPI number. So that's, I don't think it would really impact them in a negative way by any means. It would just be, are they ready to go when they do in fact become an eligible provider?
Okay. Another one here. Do you think there will be any exclusions for required elements that cannot be met?
That's a good question. That's what we're hoping to see come out during the comment period. The biggest thing that we're seeing right now is obviously the low volume threshold is the biggest exclusion. There was no exclusion for security risk analysis under ACI. That is a required measure, for example. So we'll have to keep an eye closely on those. Once again, that's something that we evaluate measures completely as part of our MIPS Plus program, and be happy to do so for a client if they need us to.
personally, my read on it is the required elements, the 4 standards under the required elements under ACI, there will be no exclusions for. I don't expect there to be. There weren't any in 2017. If you were doing either it's 90 days or full year reporting, if you were just meeting the test phase, the exclusion applied because you didn't have to report on any but just the one category or the one element. I don't see that happening in 2018. Now, the other things, when you talk about the quality measures, there are no specific required quality measures. So, that's up to you to decide the ones that you can report on. The same thing with the improvement activities. And again, those are all scoring based. The ACI stuff, the advancing care information, they are scored, but they're required elements to receive a score of anything but 0. If you don't pass all 4 of them, you get a 0 score on ACI regardless. And there wasn't an exception in 2017. I do not expect to see an exception in 2018. Okay. Oh, you took away Tracy Jackson's question. Tracy, yes. That'll be available for you. In fact, I'll deliver that to you personally at T-Bones if you would like me to, on a zip drive or a thumb drive just for you, Tracy. But no, it'll be on our website for anybody who wants to see a recording of this presentation. Okay? Healthcare compliance pros, we do help our clients with the MIPS program with potential scoring, looking at their workflows, working on their quality measures. Determining those standards is part of how Healthcare Compliance Pros broadens our reach for our clients. We're doing that for numerous groups all over the country. We would love to be bringing our MIPS expertise to your practice. If we can help in any way, reach out to us. There's a 1-800 number or support@hcp.md. We'd like to show you how our MIPS expertise can be leveraged to help you and to help your practice. And we have different levels of implementation on that. Okay, so again, thanks for your time. Any other questions that came in, Nicole?
Nope, that's all we've got for today.
Okay. So next month, we're going to have again another webinar be on the refresher module for corporate compliance refresher module. Something that's unique about HCP is the training that you get will not be the same every year. Unique. Your training is always updated, always built. Refreshers with bringing scenarios or case education in is part of how Healthcare Compliance Pros brings education to your compliance program. Everybody, thanks. Nicole.
Awesome. Thank you, Eric. So at this time, we just want to thank you all again for attending today's webinar, and we will be posting this webinar on our website, and also we will send it out in our weekly insider newsletter. Our August webinar, as Eric said, will be on the rollout of our new corporate compliance refresher module, and we look forward to attending next month. Thank you all.